Hello, I'm Saad Dino, pharmacist and co-owner of Acton Pharmacy, West Concord Pharmacy, and Keys Drug in Newton. I would like to welcome everyone back to our show, A Healthier You. Our goal is to discuss current health topics and to provide information that will guide you to a healthier lifestyle. Today, we will be discussing seasonal allergies, asthma, and other respiratory concerns for children with Dr. Benjamin Nelson, a board-certified pediatric pulmonologist at Mass General Hospital and Emerson Hospital in Concord. Thank you for being here today, Dr. Nelson. Much appreciated. I'm so pleased to have you on the show. Can you please educate our viewers on yourself and how you became a physician and why you chose pulmonology, if you don't mind?
Yeah, well, thank you, Saad, for having me.
My pleasure.
I'm excited to be
pleasure.
here. So originally I'm from Milwaukee, Wisconsin.
Okay.
Still consider myself a Midwesterner at heart.
Okay.
And ended up in D.C. at Georgetown University in Washington for medical school.
Okay.
And then my wife and I came up here in 2005 for me to start my pediatric training. So I completed my residency as well as my pediatric pulmonary fellowship at Mass General Hospital for Children, and then joined the faculty in 2011 as a pulmonologist. And currently I live close by in Boxborough with my wife Megan, my girls Maddie and Ayla, my twin girls, and my dog Hogan.
Oh, there you go. Awesome. So you're local.
Yes.
Awesome. So what motivated you to become a pulmonologist, and also what motivated you to become a pulmonologist, but also to work with children?
So it was very evident to me very early on in medical school that I wanted to work with both children and their families. Okay. Children are resilient and they're so innocent, and it's usually not their fault that they're sick, and they get better and they do well. And I find that as a pediatrician, you can really have a positive impact and influence on their health for not just the immediate period, but for the rest of their life, and you can really make an impact. So I find that really rewarding. And then I chose pulmonology because I like the mix of pulmonary disease. You can have, you still have continuity of care with patients because some of these diseases are lifelong.
Sure.
But you really get to spend time with them and focus on one particular area. Some kids are very sick and in the hospital. Some kids are just coming in for routine follow-up visits. There's procedures involved in the field, and it also allows me a lot of time for teaching as well. So it's a really nice field.
Awesome. So you're a busy guy.
Yeah.
Let's focus a little bit on asthma right now in the next few minutes. It's obviously a topic that's been around for a long time, and people have had asthma for many years. What are the causes, and what are the symptoms that would diagnose someone with asthma, whether it's an adult or a child?
So although there is a genetic association with asthma, we don't know the actual cause, why some people get it and some people don't. So I think of it as this way. It's a fairly common condition, and it affects the airways. And kids who are predisposed to develop asthma will show certain symptoms in the signs of triggers. So what happens is when you're exposed to a certain trigger, and the most common ones are viral illnesses, allergies, exercise, weather changes, what happens then is your airways get inflamed and they tighten up. And then you present with the classic symptoms of cough, which oftentimes is worse at night. You could wheeze, you could present with shortness of breath, and these symptoms tend to be intermittent, meaning you shouldn't be symptomatic all the time. You really just have problems when you are exposed to these certain triggers.
So, some of the symptoms that you just described could be, if I may say so, bronchitis or pneumonia. So how do you diagnose someone specifically with asthma disease?
So diagnosis can vary. So in kids who are usually about 7 years of age and older, they're old enough to perform objective tests called pulmonary function testing.
Okay.
So in someone who, based on their history and physical examination, you think might be consistent with asthma, you can do what we call a PFT, a pulmonary function test, to solidify the diagnosis.
Okay.
However, some offices don't have that equipment, and kids who are younger than 7 can't reliably perform that test.
Gotcha.
So in those situations, it's based on your history and physical, and then really how they respond to the medications. So sometimes you need to give an empiric trial of asthma meds and then see how they do. And if their cough or their wheeze or their shortness of breath improve, then it seems like you're on the right track. So sometimes it's, there's no specific blood test per se that can tell you yes or no you have asthma.
Okay. And genetic, going back to the genetic aspect, what's the percentage of patients that you see that have asthma, whether mom or dad or uncle or aunts have that disease as well?
I would say about half.
Okay.
About half. It's more common for the mother to have asthma.
Okay.
But we see plenty of children nowadays that they're just unlucky. No one in the family has asthma.
Gotcha.
What I would say though is that when there's no family history and children tend to become symptomatic and present early on in life, around 1 year of age, they tend to get better. Over time, usually about school age, they'll often outgrow it. But it's the kids who have a strong allergic history, a strong family history, who tend to have more persistent symptoms.
And just to get personal, that's me. I had asthma, very, very bad asthma at age 1 and 2. I turned 7 and it kind of just subsided.
Oh, great.
So I'm an example of that. And how is asthma treated?
So asthma is treated in various ways. Unfortunately, there's no cure. There's no medicine that gets rid of the asthma, so our medications really are based on controlling the symptoms. Okay. So there are avoidance measures if you know there are certain triggers, try to minimize exposure and things like that, but you want to live your life and you want to participate in all activities. And so the mainstay of therapy are 2 different classes of medications. Okay. One is a rescue medicine. This is something that you use that's short-acting in the setting of symptoms, such as persistent cough, wheeze, or shortness of breath. Okay. And sometimes that's all you need. Okay. But for those patients who have persistent symptoms despite regular use of the rescue medicine, or if their symptoms are severe enough or limit their activities, then the doctor might prescribe a controller medication. Okay. This type of medication, what that does is it decreases inflammation in the airway, opens up the airway and gives you more reserve. Okay. So that way, when you're exposed to a viral illness or the cold weather or an allergy, you have more reserve, so you might still be somewhat symptomatic, but the symptoms won't be as severe, won't be as long lasting, and will hopefully prevent significant exacerbations.
Just talking from my experience as a pharmacist, there's some individuals that will utilize that albuterol as the rescue more often than we really need to be.
Correct.
And then we say, I think you need to speak to your physician because I think you need an additional medication to help you, because the use of albuterol is awesome. I mean, it's a great medication, but the overuse can be harmful. Right. Can you just discuss that real quick?
So what I always tell families is there's a goal of how often, what's too much. So on average, you should be using that albuterol less than 2 days per week. Okay. And that's on average. So if you have a cold and you need it for a few days, absolutely, you use it, it's there, it's a rescue medicine. But if you find yourself every week needing that albuterol 2 or more days a week, then I say that's too much. Okay. And then on the other side of that is if your symptoms are interfering with your ability to sleep at night, go to school, or exercise, despite the regular use of that albuterol, then you need that daily control medication as well. Okay.
And that control is, it could be, there's tons of new inhalers out, and we talk about steroid combination with other class of drugs, and those have been tremendous assets to individuals, whether it's asthma or COPD. So
absolutely, there's a lot of choices for controller medications, and some families are nervous about putting their children on medicines every day. But I always look at it in this way: what's the risk and benefit of starting the medication? Absolutely. But then what's the risk and benefit of not starting the medication? Because when you're thinking about these meds, usually the child is symptomatic and having problems. And so the key for me is you want to use the least amount of medicine possible, but enough to control their symptoms and allow full participation in all activities.
Perfect. I think you might have hit it. The asthma rates have climbed in recent decades or recent years. Why do you think that is?
Good question, and we don't know.
Okay.
There's theories out there, but nothing is definitive. I will say we also see more allergies, especially food allergies in patients as well, and we just don't know.
You think it's environmental?
It's probably a combination of environmental, our changing kind of overall immune system with antibiotic use and other things like that. And we're probably better at diagnosing it sometimes too.
That's true, too.
But I agree with you. The CDC actually states that about 8 in 100 children are diagnosed with asthma. So that's a lot.
That is a lot. I think we hit on this earlier as well. Cold temperatures. I remember when I had asthma.
Yeah.
When I go outside, I start coughing within 5 minutes.
Yeah.
Why?
So cold temperatures can be a trigger for asthma. Now you have to remember though, not all asthmatic patients have the same triggers.
Sure.
So one child might be affected negatively by the cold temperature where another is totally fine.
Very individualized disease.
Yeah, so we're living here in the Boston area. It's cold for a majority of the year. And we want these kids to be outside and playing because we don't want them to be having to stay inside.
Okay.
So it definitely can affect your airways. There are some things that you can do to kind of minimize those symptoms. Appropriate clothing is always helpful, especially wearing a scarf that's kind of loosely fits around or over your mouth and your nose. So that way when you're breathing in and out, it's the air that you're breathing in and out is a little warmer, a little more moist, and that can help minimize the symptoms. And sometimes you might even take 2 puffs of that rescue medicine as a preventative right before going out in cold temperatures. But most of the time that shouldn't be necessary.
But what's the trigger? Do they know why?
It's I don't think I could tell you exactly what is happening at a cellular level, but we do know that that type of air just can be irritating when you're breathing in, especially if you have, for instance, a stuffy nose in the wintertime and you're not breathing through your nose, which is going to moisten that air, and you go right in your mouth and it goes in the airways. So it can be irritating.
So, you know, during the winter time, a lot of children and adults get colds and flu and those types of illnesses. When should a parent comfort a child with traditional measures of rest, warm liquids, over-the-counter perhaps medications, as opposed to seeking medical attention?
So it'll definitely vary based on the family and their comfort level. But there are a few things that I would routinely say, you know what, you should probably be checked out. So if your child's having fever that's lasting 5 days, at that point, you should probably just make sure nothing else is going on. The other thing is hydration. So as long as you can keep your child drinking and hydrated, kind of a rule I use is your child should be urinating about once every 8 hours on average. So if you can keep them hydrated, you're good. I don't worry so much about eating, but as long as they're drinking, they're okay. And then strictly from a respiratory exam, things to look out for, fast labored breathing, belly breathing when their stomach goes in and out, or sometimes you can even see little indentations in between their ribs to tell you that they're working harder to breathe. The key there, though, is you want to see if they have a fever, because if they do have an elevated temperature, that can make everything worse. It can make you look more uncomfortable. It can make you breathe faster and more labored. So I would caution families to say, bring down the temperature with an over-the-counter fever reducer, and then reassess your child. And then if they're still not looking right, then go in and see the doctor.
So the pain reliever and the ibuprofen perhaps for temperature control is fine. There are some over-the-counter stuff for children that I sometimes think people are overusing in children, trying to give relief symptoms of such cold or flu. What are your thoughts on that?
Yeah, so I don't recommend any of the over-the-counter medications for the cold and flu for kids. Usually they're getting them for either nasal congestion or cough is a big one. And we find that they're not very effective. And you can run into the problems of unintentional overdoses because they have certain types of medications in there you might not be aware of. And so I don't recommend any of the over-the-counters for treating colds. Unfortunately, you just kind of have to let them work their course.
And, you know, we also recommend to parents that come to our stores is that, you know, check with the doctor or check with your pharmacist on dosage because, you know, especially with acetaminophen or ibuprofen, you got to be careful.
Absolutely.
Too much could be very harmful. And, you know, always read the labels and check with your pharmacist and doctor to ensure that the dose is given accurately to the
Yeah, because those
child.
over-the-counter medicines often have acetaminophen in it.
Correct.
And then if you're also giving acetaminophen for fever,
Right.
you might accidentally overdose.
Correct. Thank you so much, doctor. Similarly, at what point should a parent be alarmed or go to the physician when there's a persistent cough? How long should they wait, I guess is the question. And whether it's a child had asthma or non-asthmatic.
In general, kids are going to cough and cough a lot over the winter months.
Okay.
And the usual pattern is if they catch a cold, a cough can last about 7 to 10 days.
Okay.
And then the hard part is kids get colds after cold after cold, especially if they're in daycare or school.
Yeah.
And so when is it just one long cold versus repeated colds? So what I say to the families is if there's coughing that's going on for 7 to 10 days, we're just going to have to live with that a little bit.
Okay.
But then once it starts lasting longer than that, ask yourself, is the cough waking the child up at night? Is it limiting their ability to go to school or limiting their ability to participate in their daily activities? And if so, and it's lasting longer than those week to 2 weeks, then I think it should be evaluated. Because then it starts getting into a more prolonged cough, and you want to make sure there's nothing that you can do to help that child get better sooner.
So that prolonged cough will become what we consider chronic cough. So how do we treat that chronic cough? Once that 2 week period is maybe they shouldn't wait that long, but if they're waiting too long, for that cough, what's the next, when they come and see you, what measures do you utilize?
So the strict medical definition of chronic cough is 6 to 8 weeks of cough,
okay,
but
fine.
to be fair, I think that's too long.
Okay.
I wouldn't want a family necessarily waiting 2 months before they sought medical attention, especially if the cough is interfering with things.
Okay.
And so the treatment varies based on the etiology, so what's causing the cough. So the physician's job will be to determine are there any signs of asthma, and if so, would it be appropriate to treat with those types of medications.
Okay.
The other very common causes of cough like that in kids are postnasal drip from either allergies or just you're just stuffed up from a viral infection. Gastroesophageal reflux disease can cause cough as well.
Yep.
And so when you have that prolonged cough like that, it will be the doctor's job to try to figure out what's causing it, and then based on what they think is going on, they'll try to suggest certain therapies. And then the key for me is whenever you're trying a new therapy, always see that child back within a few weeks, because 2 weeks, 4 weeks, whatever it is, because you want to make sure your treatment is working.
Okay. Wheeze. What does wheeze indicate to you when somebody's wheezing?
Well,
whether it's asthma or otherwise.
Well, wheeze is a tricky word because my definition of wheeze as a pediatric pulmonologist might not be the same definition that a parent is using.
Okay.
And so I actually, believe it or not, try to mimic the noise or have them mimic the noise for me in the office.
Okay.
Everyone's got an iPhone nowadays and they take videos of it, and that can be really helpful.
Okay.
Because wheeze by definition is a loud, high-pitched sound when the child's breathing out, as opposed to breathing in and hearing a loud pitched noise. Now, you might not think that might be much of a difference, but it actually suggests different etiologies for the symptoms for the doctor. So it can be really helpful for the physician to hear what is exactly going on. But if you do hear wheeze, probably the most common reason for that would be asthma, but it doesn't equal asthma. There are plenty of patients I see who have wheeze for other reasons, and so sometimes it can be challenging figuring that out, but it's important to do so.
Okay, great. I think one of your specialties I read is tracheomalacia. Can you explain what that is and how do you treat it?
Yeah, so tracheomalacia, it's a long word, but trachea is the main airway right here, and malacia means floppy. So tracheomalacia means a floppy, underdeveloped main airway. It's a benign condition. Kids are oftentimes born with this, and it manifests itself usually within the first couple months of life. So pretty early on, earlier than you would expect asthma to present. And what happens is these patients will have prolonged cough. The cough can be dry and harsh, loud, almost like a smoker's cough, if you will. But it can also be juicy. You can feel a rattle in the chest. Sometimes you'll hear some loud, noisy breathing and you'll see some labored breathing at times as well. And I ask parents what makes these symptoms better or worse, and oftentimes they'll tell me it's worse when the child is lying flat on their back, when they're crying or agitated, or in the setting of colds. So what happens here is they come to see me with these symptoms, and if I think it's consistent with tracheomalacia, we treat empirically. Because the gold standard for diagnosing something like this is an invasive procedure where we put the child to sleep and look in their airways.
I see.
So what we do first is, if the symptoms are consistent, I'll use medications on an intermittent basis to try to open up the airway, dry up some of those secretions. But the key is they're different medications than you would normally use in the classic asthma. So it's important to differentiate between the two.
Okay, and then, there's also a bronchoscopy. So how does that, is that what you were saying when you put, is that the procedure you do?
It is. So bronchoscopy is a procedure that we'll use, and I use frequently. I'm the director of the Pediatric bronchoscopy program at Mass General, so I do this a lot. And indications for that vary, which we'll talk about. In the setting specifically of tracheomalacia, the indication would be if your child's not gaining weight, not feeding well, or repeated respiratory tract infections. So it usually takes a while to get there. But if we use bronchoscopy, it's a safe procedure. We use general anesthesia in conjunction with pediatric anesthesiologists. So your child's asleep and safe. And then we take a long tube with a camera at the end of it and put it in the child's airway. And then we can look. We can see, are the airways normal? Is the anatomy normal? Are there any anatomic reasons for the symptoms? We can use it for diagnostic purposes, so we can see if there's any infection that we're missing down there. We can see if there's a floppy airway in the setting of tracheomalacia. And we can also use it for therapeutic means. The most common reason there would be if a child develops a cold, and their natural host defense response is to make secretions in their lower airways. But because they're young and they have somewhat of an underdeveloped cough and their airways are smaller than yours or mine, that mucus can get stuck down there. And so parents will come to me and saying there's congestion in the chest and a prolonged, chronic, juicy type of cough that really isn't responsive to any medications. So the bronchoscopy can be useful because we have the capability, when we have that tube in the airway, to physically suction out and remove those secretions. And oftentimes kids will be markedly improved immediately after they wake up from the procedure.
So it's all just that mucus that's stuck in there.
Exactly.
It's causing all those symptoms.
Yep. And mucus begets mucus. So if you have some down there, you'll have more. And so you got to get rid of it.
Okay. And I'm sure it's an uncomfortable procedure, but again, these are done under anesthesia, and they've been monitored and such. It's
actually a relatively as far as procedures go, comfortable for the patient. We don't actually intubate the patient with a tube into their airway, which can be irritating. They're breathing on their own. They might have a little bit of a sore throat afterwards, but actually they tolerate it really well, and most kids are back to their normal activities the next day.
Wow, incredible. I think we hit on this, Dr. Nelson, a little bit on allergies and colds. How often, you're a pulmonologist, so you most of your patients are asthmatic, but how often do you say, no, your child doesn't have asthma, they have seasonal allergies?
Very common. Asthma and allergies can actually run together. So a lot of patients who have asthma will have allergies and vice versa. Not necessarily, but a lot of times we see that. And so being able to distinguish where the symptoms are coming from, are they coming from the lower airways, which is more suggestive of asthma, or maybe from the nose and the upper airways, which is more suggestive of allergies. And so it's very common that I see that, and you got to tease that out.
Okay, and the question, can you just, for our audience, for the parents that are watching this, what's the difference between a flu and cold?
So the flu is an illness that is specifically due to the virus influenza. Our best protection against that is the flu shot. It's not a guaranteed protection, but it's the best protection we have. Those kids tend to be sicker than the common cold. So if you actually have flu, usually you'll have high fever, you'll be lethargic, you'll have no energy, and it can take a week or so to get better. Patients with asthma are more susceptible to more severe symptoms with the flu, as opposed to the common cold. The symptoms are just less severe. You may or may not have fever. You can have nasal congestion, cough. You can still be fatigued, but usually it's just not as severe as the actual flu.
Okay, and thank you for saying something about the flu shot. I think it's an influenza. It's very, especially somebody that has a chronic condition, or even non-chronic conditions such as asthma. I think it's important that individuals get those with a child or
absolutely.
And this is the time
And I would say that some children are too young for the flu shot. Kids younger than 6 months of age can't get it. So in those situations, especially, it's important for any of the caregivers to get the flu shot themselves in order to protect the child.
Awesome. Thank you for that. That's perfect advice. Thank you, doctor. So we're in 2017, almost 2018. The allergy treatments, can you just discuss that a little bit? Because I don't, have we made gains? Tons of people come fall or spring, have tons of allergies.
Yeah.
How often do you see that in your office?
All the time.
Okay.
I actually never had allergies till I moved to the Boston area.
Oh.
And now I have terrible springtime allergies.
You're stuck here now. You can't go back. Okay.
So there are medications you can use, but I find that environmental strategies can oftentimes be really helpful. So sometimes you know what the child is allergic to, but sometimes you don't. The three most common allergens that I encounter in kids are dust mites, pet dander, and pollen.
Okay.
And so if you're allergic to dust mites, those are around all the time. Doesn't matter how clean you keep your home, everyone's got dust. Yeah. And so some things you can do to help minimize your exposure. Okay. Try not to sleep with stuffed animals, which sometimes is hard for the kids.
Yes, I've been
I encourage parents to look into dust mite covers. So there's actual covers that you can put over the pillows and the mattress to minimize exposure to dust mites. Okay. And then a key that a lot of people don't realize is you don't want to use a humidifier if you have a dust mite allergy, because humidifiers can actually make dust mites replicate.
Interesting. Okay.
The next one is the pets. Yeah. So I never recommend to get rid of the pets. Yeah. I'm a dog owner. Yeah. They're part of the family. I get it. Yeah. But I say keep the if you can, keep the animal out of the child's room. Okay. That's where they're spending the most of their time. So if you can minimize the exposure there, then you can get some benefit.
Awesome.
And then as far as the pollen allergy goes, they're very big, both fall and spring, especially in the springtime. I recommend keeping the child's window closed, using air conditioning when possible. And then if you're outside in a high pollen count day, I tell the child to change their clothes or take a shower or a bath before they get into bed that night so they don't bring the pollen with them.
You mentioned a humidifier, but how about a vaporizer? What's your
I don't find, there's no medical data really to suggest that vaporizers do anything or help in any way. I don't think they're harmful. Okay. So it's kind of up to the family, but I don't think they're harmful.
Gotcha. Thank you so much, Dr. Nelson. This has been a tremendous talk about asthma in pediatrics specifically. How could people get in touch with you? Yeah, so I'm based at Mass General, but I also do clinic 1 day a week out here in Concord through Emerson Hospital. Thank you again, Dr. Nelson, for joining us. Much appreciated. Thank you all for tuning in to a Healthier You episode. I'm Saad Dino, co-owner of Acton Pharmacy, West Concord Pharmacy, and Keys Drug in Newton, and I look forward to seeing you around town. Be well.